The past few decades have witnessed enormous progress in secondary prevention after myocardial infarction. Abundant trial data have established that appropriate use of aspirin, statins, beta blockers, and inhibitors of the renin-angiotensin-aldosterone axes reduce cardiovascular risk post-MI. Yet an unacceptable burden of recurrent risk remains. For example, in PROVE-IT, despite high-dose statin and other standard therapies, in the 2.5 years after an acute coronary syndrome, over 20% of patients experienced another cardiovascular event. Convincing data implicate inflammation in atherothrombosis. Inflammation can promote plaque rupture and thrombosis. Inflammatory cells enter the lesion and produce pro-inflammatory cytokines and other mediators. These inflammatory stimuli promote smooth muscle cell migration, proliferation, and lesion progression. Inflammation also weakens the collagenous skeleton of plaques, rendering them more susceptible to rupture. In addition, inflammation increases production of the potent procoagulant tissue factor that triggers thrombosis of disrupted plaques. Can clinical monitoring of inflammatory burden help personalize treatment for our patients? C-reactive protein, or CRP, provides a clinically useful biomarker of inflammation. As part of the acute phase response, which helps the body fight pathogens and repair injury, the liver synthesizes CRP in response to the inflammatory cytokine interleukin-6. CRP levels can rise by more than 1,000-fold in acute infection. In contrast, fibrinogen, another acute phase reactant, rises only a few-fold during this response. Measurements of CRP with a highly sensitive assay, hsCRP, can track the subtle elevations that indicate elevated cardiovascular risk. hsCRP measurement uses a reproducible, widely available, and inexpensive assay. hsCRP does not vary according to time of day or after meals. These advantages make CRP more reliable than other inflammatory markers such as fibrinogen. hsCRP levels increase during chronic plaque inflammation, but also with non-vascular inflammation, for example, in rheumatoid joints, periodontitis, or bronchitis. Mounting evidence indicates that inflammation, arising from either vascular or extravascular sites, enhances the risk of atherothrombotic events. Thus, although CRP may not itself increase risk, it reliably reports on the overall inflammatory burden that drives cardiovascular events. Indeed, a large meta-analysis of over 50 long-term studies showed that hsCRP predicted first-ever events as well, if not better, than systolic blood pressure, total cholesterol, or non-HDL cholesterol. In addition, large studies such as PROVE-IT have consistently demonstrated that hsCRP also predicts recurrent cardiovascular events in people who have already suffered a first heart attack or stroke. In PROVE-IT, participants on statin therapy who achieved below median levels of both LDL and hsCRP enjoyed better outcomes than those with above median levels of LDL, of hsCRP, or both. Based on this compelling body of evidence, guidelines published in the US and Canada now include hsCRP as a validated cardiovascular risk marker. Can hsCRP help target therapy in people with no known coronary heart disease? The JUPITER study addressed this question. In JUPITER, elevated hsCRP identified apparently healthy people, but with above-average inflammatory burden, who benefited from statin therapy despite having currently acceptable LDL levels. The statin treatment decreased a variety of pre-specified endpoints, including death. In JUPITER, patients who reduced hsCRP below 1 mg per liter and LDL below 70 mg per deciliter had a nearly 80% reduction in risk. Based on a wealth of data and published clinical guidelines, hsCRP has joined the ranks of traditional risk factors such as LDL cholesterol and blood pressure as a powerful predictor of cardiovascular risk. hsCRP readily and reliably assesses inflammatory burden, and promises to personalize targeting of anti-inflammatory therapies to prevent cardiovascular events.